Olá a todos, estão bem-vindos a mais um podcast, mais um Osteotalks. Desta vez estamos aqui reunidos com o Dr. Jorge Esteves e o Dr. Kesava Sampath. Espero que tenha dito bem, pronunciado bem o nome do doutor. Vou, a partir deste momento, portanto, vamos falar sobre os mecanismos da terapia manual, vamos falar sobre os desafios da profissão atualmente no que diz respeito à metodologia científica. Muita coisa se tem discutido hoje em dia sobre o que é que está de bem e o que é que está mal dentro da osteopatia, a que caminhos futuros é que se delineiam, o que é que podemos fazer enfim, para melhorar aquilo que é a nossa ação, nossa participação no sistema de saúde, como é que podemos melhorar a investigação, todos esses assuntos que são muito prementes, são muito atuais, e basicamente é sobre isso que vamos discutir. A partir desta altura, então, vou incluir o Dr. Kesava e, portanto, vou falar em inglês, e vai ser o resto do podcast vai ser em inglês. Então, temos como nosso convidado também o Dr. Jorge Esteves, que não precisa de apresentações, ainda assim, como é evidente, eu vou apresentar os dois. Okay, thank you, Dr. Kesava. Sorry, I was just explaining the podcast in Portuguese, just introducing the content and just saying basically hello to our viewers. So the podcast today will have a double participation, Dr. Esteves and you. We're gonna talk a little bit about the mechanisms around manual therapy. I think it's a present topic, and also always good to come back to what research is telling us in the contemporary kind of view world. What do we know more about this type of underlying mechanisms? It's very important because in our profession, maybe in manual therapy in general, we also have this sort of beliefs that have been passed through generation and from teacher to student, and sometimes we don't really challenge those beliefs. And
Still there?
Oh my gosh, this is not going well.
No worries.
You can edit at the end. That's it.
Yeah, you should be able to edit the recording, so we can just
Yeah.
Okay, don't.
So we do have these challenges now and then, and we have a lot of cognitive bias that we have this. I believe Chad Cook wrote very recently. We have this illusionary kind of ideas that many times don't correspond really to reality, at least to what we know. So this is a very hot topic today. So I'm just going to give a short presentation. Dr. Jorge Esteves is an osteopath, PhD, is a very experienced academic with expertise in osteopathic and healthcare education, research and development. His research interests are focused on reconceptualization of osteopathic care under the inactive free energy principle, which includes a critical consideration of theories and research from ecological psychology, embodiment and inactivism, free energy principle, predictive coding, interoception, allostasis, chronic pain, etc. We had them on the podcast already. I mean, it's quite well known in the Portuguese community and international community as a vast publishing. He publishes a lot in very important journals. He's also a vice principal at ICOM Malta. Is the director of medicine academies. Is very much involved in academia and osteopathy. Dr. Jorge Esteves, thank you so much for being here. Dr. Kesava Sampath is a registered physiotherapist and osteopath in New Zealand. He's a PhD. His PhD research was in mechanisms of manual therapy. Interests of research include investigating the mechanisms that underpin manual therapy practice and its implication in clinical practice, especially for people with chronic pain. Dr. Sampath is a principal academic staff member in the Centre of Health and Social Practice at Waikato Institute of Technology in New Zealand, where he's teaching in the physiotherapy program. And thank you so much, Dr. Sampath, for being here, for being present. quite an example of academic pursuit, academic achievements. Both physiotherapists and osteopaths will give also a broader kind of idea of manual therapy in general, you know. And I'm sorry for my finger. My finger was butched 5 minutes ago in the kitchen, so I'm wrapping my finger to make sure it doesn't splash blood all over the screen. So let me say thank you, and let me start with this question. As I was saying, there's never been a time maybe where I feel we're at this crossroad. We can go left, we can go right. It's very important, this type of questions, you know. And there was a recent paper from Dr. Oliver Thompson, "What's Wrong with Osteopathy?" So we're kind of on this crossroad where we're being forced to look at the profession and now I'm referring to osteopathy in particular, look at the profession, look at this, like Chad Cook said, this illusionary effect of the things we think we know and it's not really true, this kind of cognitive bias. So we're really being pushed to examine, to question our profession in terms of evidence based, in terms of research. Where do you see this? Where do you see this crossroad? Where do you see this moment? And this is for you, Dr. Kesava. What do you feel about this that I just said? What is the importance of this discussion that is being really? We can see there's some sort of a paradigm shift where it feels that the profession is quite polarized. Some people go right, some people go left, some really defend their beliefs to the very core, and now it feels that we need to find kind of a middle ground to push the profession forward. What do you have to say about this?
Thank you. Firstly, thank you so much for having me on the podcast. Thanks for the opportunity. And I think the questions you're asking, and I think the podcast, the nature of the podcast and the questions are quite timely. As I completely agree, that can't be a better moment to discuss about mechanisms in manual therapy. To kind of unpack your thoughts a bit more, I think there are quite a few layers or quite a few questions tagged into the main question that you're asking. Firstly, I think the research around mechanisms has been building. It's not happening all of a sudden. It's been building over probably a decade, if I'm not wrong. So what we are seeing now with papers from Chad, papers from George, papers from some physiotherapy colleagues as well is more probably showing up now, but it's been ongoing for last 8 to 10 years, or 10 years at least. Regarding your question about being in the crossroads. Again, I think we have been in the crossroads. It's just probably not a new spot for us. We have been in the crossroads for a while. Honestly, my personal take on that is it's okay to be on the crossroad. It's like anything else in life. Like we make decisions, we progress, and then we come to a point where we're like, oh, should I go right, left, or straight? So profession is I think it's similar. It's really good that now we are really taking a hard look at what as a profession, what sort of research do we want to do? What sort of profession are we? Is it illusionary effects? Is it physiological effects that we are focused on? Is it patient-centered approach that we are wanting to do, et cetera, et cetera? I personally think probably crossroads is not a great example for me. It's like, because you will take a left and then you will be at a crossroad again. You take a right, you'll be at a crossroad again. So it's always good to add layers of research and progress the profession in a pragmatic way. I think the moment we say left or right, we are then creating the polarization, and there'll always be people who would be arguing for the left and arguing for the right, whereas probably we all know probably the truth is at the center somewhere. So I think we need to take a pragmatic approach and taking everyone as we go along this journey. I kind of think that's my opinion, to take everyone on and see where we can't just say there is one way of either doing research or one way of doing osteopathy, because we know osteopathy is quite broad. And that's the beauty of osteopathy in some ways. We can't ignore someone's perspective. So probably the more research we do, probably we will build more evidence towards various aspects of osteopathy, and probably we can be at crossroads again after 5 or 6 years.
Yeah,
That's my take
yeah,
on that. Yeah.
thank you. Yeah, and I agree with you. This idea of crossroads, it just feels like, and it's important also. It feels like in some moments of history and life, as you said, life is full of challenges. And there's some moments it feels more polarized, and it feels almost like we're talking in different, really defending to the core one position and another. But then, of course, to progress, we need to find a common ground. It just feels like that, but in a hyperbole. No, it's like an exaggeration of the thing, which I do agree, which is very important to discuss. I think a profession that is incapable of discussing itself and looking inside, it's something very stagnates and just freezes in time. Jorge, what's your take on this? What do you feel about this question that I asked, this moment that we are in?
I entirely agree with Kesava on his interpretation. I don't see too much of a problem being the crossroads or getting to a place where we need to decide really, should we continue on the same journey? Should we move, sideways, right, left, or whatever is appropriate. I think partly, and I think, if you put this in the context, and of course, research on mechanisms on manual therapy has been going on for a few years, and clearly, I think, if we go historically, people thought that osteopathy or any other form of manual therapy was all sort of force-based. We're kind of you're gonna cause some structural changes in the tissue, in the structure. You're gonna change position. You're gonna improve posture. And clearly the evidence doesn't show that. That's the case. Clearly most of the evidence is around the neurophysiological stuff, but also there's a lot of the other stuff, the contextual factors that are key to the whole thing. And I think when what we see with the discussions, and the discussions on Twitter, for example, tend to be extremely polarized around, when some particular individuals open the can of worms around manual therapy, here we go. And is either my critical take on things is, manual therapy sucks, but so the solution for everything is a deadlift, like some people have argued about, a particular kind of, member of the Twitter community. So I think it can be quite polarized, and for us, and I think you see that with the papers, with what's wrong with osteopathy, with the replies to what's wrong with osteopathy, which tend to bring a critical element into it, and also try to contextualize things. It's very easy to say, for example, you can be super critical about somatic dysfunction doesn't exist and so on, but also is a foundation for for regulation in some countries around the world for osteopathy. So you can't just remove everything, because then those guys come from those countries, say, then so what? What's left? What's the uniqueness about the profession? The other thing that I see with the polarization, manual therapy or osteopathy, is people tend to confuse the difference between the therapeutic intervention and the profession. We are much more than manual therapy. The same physiotherapy is much more than manual therapy, because, of course, physiotherapy, you can have 3 main branches. I can't see many attacks on the neurological, cardiorespiratory sides of physiotherapy, but I can see all the attacks on the musculoskeletal side of the physiotherapy, because is this tension dichotomy between, is manual therapy or exercise? Is it one thing or another? A few years ago was all pain education, pain neuroscience education, basically say, just have a chat. Then we see from within our own profession, from osteopathy, the attacks that, I think people sometimes forget that we don't just do manual therapy. We listen to people, we interact with people, we use hands-on care. I prefer use it, the term hands-on care rather than manual therapy. And we're not manual therapists. We are osteopaths at the end of the day. That's a profession there. In the same, I don't turn to a physical therapist that does manual therapy and call him or her just a manual therapist. It's much more than that. Is a profession with a set of values, the set of, kind of rational, maybe philosophical stances and so on. And that's where we come from. When we do the hands-on care, it's contextualized. Yeah, okay. When we're talking about mechanisms, are we kidding ourselves to believe that everything is physiological, everything is structural? Of course it isn't. There's an interaction between two people, or sometimes more than two people in a room, and that interaction changes outcomes. How can we decontextualize things? Just basically, does manual therapy work or not? Okay, for what and in what context? Why does it work with some people, doesn't work with other people? Are those guys sort of better responders than others? So, it's much more complex, and I see it as extremely easier to attack if we don't come from an understanding that we're talking about, a profession, and people use different approaches, people have different value systems and so on, and all of that contributes to what we do. So, and I think if we go on the world of social media these days, is the more visceral you are, the more crazy, the more shouting you do, the more likes you get. So what we see, that's the world. It's pretty easy to jump on that bandwagon and get some likes and be a cool kid, but really sometimes forgetting, actually, with some positions, you can potentially destroy things as well. So that's, particularly for people that have more senior roles in the profession, I think it's also important to kind of, critically analyze, reflect on the positions, because, it's easier, just giving ammunitions to the other side. That's my take.
Yeah, I think when we discuss polarization, I think one of the key questions we need to really ask, I suppose, is who's getting polarized? Is it, like Georges is saying, is it some social media influencer? Influencers are there in every profession, not just osteopathy or physiotherapy. We know in politics, we know in general life there are influences, and I think we have to put some basic evidence-based foundation principles when we follow certain Twitter threads. I follow a lot of professors, academics, respected colleagues. Sometimes I agree with their views, sometimes I don't. And that's really important to put that kind of filter on, because everything that we read in social media, just because it's said by a certain individual or an influencer, may be right or wrong. And if that is the case, then we are going back like 30 years back, when I trained, this is what you do because I teach you how to do it, because I'm the guru, I'm showing you something. We can't take the same approach in social media and go, just because this person has said it, I'm just going to just believe it. I still have to use my own evidence-based knowledge to say, okay, dig in a bit deeper. Why are they saying this? And then we start to decode some discourses, right? And then the discourses are so powerful. The narratives we set in social media are extremely powerful. We know that. Therefore, we need to really engage in some sort of discourse analysis and see whether their anti-manual therapy opinion is just an opinion, or is there any science to what they're saying. If there is science to it, then we have to really acknowledge that and see how we can scientifically defend their viewpoint, or how can we add some of the Twitter comments. The Twitter threads are amazing. Like, they can trigger more research in manual therapy because they're asking some critical questions which we don't even ask ourselves. And then we have to say, oh, thank you so much. I didn't think about it. Thanks for thinking about it. If I'm making sense.
Yeah, absolutely.
Yeah. And it's also when I think at least for me, my concern is also, I mean, you guys are two examples of just a posture which is an open-minded kind of, it's promoting dialogue posture. But sometimes what I feel it's inside the profession is not this, is not so much this. It's like there's really that tension to a point that the dialogue is not possible anymore. And I don't want to refer names, but it's like, it was very clear recently where something that can bring the discussion, it's important, but then it kind of it's blocked at different levels, and this is what is concerning. It's blocked at different levels. The continuation of the discussion is like one-sided, like it's more kind of it's right and the other side is wrong, like kind of like this. But anyways, this is part of life, and this is something that I've seen in the and also in the master's program now recently, which is, again, it's not a new discussion, it's not a new debate, but it's been going on. And there was a recent paper, I think 2 or 3 years ago, from physiotherapy that actually discussed this, the pragmatism approach, pragmatism's methodology, instead of just a quantitative or qualitative methodology. When we're talking about contextual factors, when we're talking about the interaction of two human beings, having a sort of a pragmatic approach, pragmatic methodology would be more, much more reality, much more in tune with reality than actually the conventional methodology, which is either quantitative or qualitative in professions like osteopathy and physiotherapy. You, Dr. Kesava, what do you feel, since you have both worlds in your academia, what do you feel about this type of where are we heading with this sort of research that can actually really figure out, or as much as we can, what's happening within the hands-on care treatment?
Thank you. So I think the nature of research, or the paradigm or study design, I think it really comes down to what question we are asking. Do we want to like capture the exact effects that happens with osteopathic intervention, like what I will do in clinical practice? Do I want to capture that in a research form? Then probably yes, pragmatic approach would be really good, where I have some objective outcome measures, but also patient reported experience measures, so I can then match it up. But I see there is place for any research design, and we should take advantage of every research design possible to build our profession, because then we don't want to we don't want to end up in a state where we're like, oh, 5 hours of just pragmatic approach, and then we will be at a crossroads again. So it really depends on what question we're asking. So if I'm asking a really fundamental physiological effects sort of a study or a question, then I really need a lab well-controlled trial, quantitative outcome measures, name them, just hypothesize how this is going to work and see if there is evidence for that or not. On the other hand, if I'm really interested to know what my patients are feeling, I really want to engage in a qualitative study, listen to them, ask them some questions, form some themes. So it really comes down to, I think, a research question to capture osteopathy. Of course, I think, or manual therapy in general, I think a pragmatic design is appropriate.
George, do you want to have something to say about this?
No, I just endorse that view. And that's the kind of discussion I had with my students when they come and say, I would like to do this kind of study and so on. And, I'm doing a review for X, Y, or Z, whatever. It starts with the basic foundation of science. So ask the question, what is your question? If you've got a clear question, because also it's linked to a need in the literature and so on, then you can kind of decide which direction, what's the most appropriate direction of travel. And clearly we can't just say, we can't just continue on doing the same thing and finding exactly the same thing if we don't sort of then understand why we find the same thing. So, you can do many RCTs looking for the same thing and then kind of, all right, we've done them, we've been there, we're repeating the same thing and we find the same kind of outcome and we all feel depressed about it. Then of course other questions need to be asked, and we need to understand the whys and so on, right? So yeah, absolutely. So it starts with the question, starts with also I think an important thing, and sometimes that's not, I think that's a little bit of not understood within the profession, is that there are questions for which there are actually no ways yet of investigating that question. Maybe there's no methodology, maybe there's no way that to kind of answer that question. Another thing that sometimes you tend to find in the profession, or in particular in some groups within the profession, is the idea that we need to find out if osteopathy works. Well, that's not science, because if we're going to find out, if something works, you already have a kind of a bias of what do you want to find out, and also an understanding that a misunderstanding that actually a research question needs to be answerable. So if you've got a question of does osteopathy work, for what, in what sense, and so on, how many questions can you develop as a result of that big question, or even just a question, what is osteopathy, would be a question that doesn't have a simple answer. I think sometimes, it's people have a holistic view of the world, of their patients and so on, and struggle at times to actually get stuck in a very small and very well-defined question that might actually take the whole life to answer. But that's actually what science is about, isn't it? And I'm here, when I talk about science, I don't talk about science as just being from a 100% positivist approach that everything needs to be done with an RCT. Science is science. You can ask, you can do science by asking questions. And do social sciences is science, for example, and doesn't do RCTs, for example. So, it starts with that question, starts with that genuine kind of understanding, why. Yeah, and where do the questions come from as well? Questions come typically from experience, from clinical practice, isn't it? Something people observe, oh gosh, my patients get better. I don't know why. Is it me? Is it the context? Is it the technique? Is it what? But, they're getting better. So yeah, clearly there's a question there. Why do they get better? What's going on? What's the process? And so on. So I think that's still a lot of work to do in our profession, but not just our profession. I think sometimes we feel too depressed about what's going on within osteopathy. When we look around, actually, the debates are similar, okay? But either the professions are bigger, for example, you don't see that in medicine, for example, but clearly there's a struggle in some interventions. Why do I decide to do, for example, just thinking about, in orthopedics, in a surgical intervention, why do I need to, why do I go for a knee kind of arthroscopic approach, if the patient has osteoarthritis, for example, where the evidence says that doesn't work, for example, but, I think, you should go for that, So that's not too dissimilar to what we're talking about. Oh, let's do manual therapy, let's do hands-on, but there's no evidence for it. But I can't, we can't see too much of that sort of, within the bigger world of specialties within medicine, that actually people kind of attack themselves, and actually question, maybe they should as well. Okay. And then actually the problem is not just with professions like osteopathy, just thinking that.
I completely agree with Professor Georges. I think I sometimes feel that it's easy to target manual therapy, as simple as that. But the critical questions are exactly similar. Where I talk to physiotherapy colleagues and we discuss about the same things. Even exercise therapy, right? How does exercise work? Or it could be stretching. How does stretching work? Or it could be hydrotherapy. How does hydrotherapy work? And I think these are all questions that actually actively come from clinical practice. So I did this, and this patient improved, but this patient didn't. I did exactly the same thing. Why? What's the difference here? Is it interaction? Was I stressed when I saw patient B? Or they didn't understand my accent? Or is it something cultural that's going on? There are so many different variables, and we can't exclude those variables. I think one of the things with science, building science, is there's quite a few layers. Like typical science would tell us that these are non-specific effects, so therefore we can't consider them. But we definitely know that these are essential things that actually make someone feel better. So then it kind of leads us to two pathways. One is, who are we actually creating this evidence for? This is what has been going on in my mind for last year or so. Like when I'm researching for whom, is it for my understanding? Yeah, absolutely. There's a bit of selfishness there. I need to know what I'm doing to my patient. I need to know what I'm doing in my clinic. In a way, I'm building evidence. Is it for my profession, or is it for some other profession that's judging me using the scientific lens, where all the things that I would value, like non-specific effects, contextual effects, communication, patient-centered approach, blah, 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 they're kind of just written off. It's like, no, we don't want to know about this. Tell us what's your p-value. So then it's like, irrespective of whatever paradigm that we may engage doing research in, if we are doing research to be accepted, then who's accepting us? Whether whether we need to be accepted, or so it's a clearly different discussion. I don't want to go too far from our main theme, but I think that's when we need to have different approaches, different study methods, and even some sort of discourse analysis, teasing out these power imbalances within the health profession, where we are clearly probably down the, at least in New Zealand, we are not part of the health system here. So clearly down the pecking order. So then what do I do to claim my probably stake in the room? Where is my voice? Who wants to hear my voice for a start? Why should I train to sing if nobody wants to hear my voice for a start?
Yeah, and it's what do you think that? What do you guys think that is? It's a very important question. Who's assessing me? Am I proving this to whom? Because if we look at this bigger picture, let's say the medical kind of not attachment, the medical conservative, building. I mean, let's go to COVID-19 and the whole way that the whole thing got managed. Let's go to the vaccines and this things that we know now about the vaccines and how the methodology went. So who's really, I mean, not to be too critical, but who's judging me? And why do we have this need of proving ourselves? Why this manual therapy? Is it because it's not really firmly into health systems, like firmly recognized, or is it because it's a hands-on thing and it's not really? We have this again, this cognitive kind of belief, this biased whatever, that pills are the only thing that works, or surgery, anything else besides that it's not, because it's not. Why is it manual therapy so vulnerable to this type of attacks? Is it because they're hands-on, or culturally, or what do you think that is? Why do you think that is?
Well, where should we start? I think in the bigger world, clearly, if you do a manual intervention, you don't sell anything. You just don't sell. Smart pharmaceutical companies will not be interested in you because you just sell your hands-on stuff. Okay. Now, manual therapy has been sort of around for many centuries, right? So it's a sort of well accepted, form of treatment. Yeah. Manual therapy. I remember, when I started working in Portugal in the 1990s, you would look at, the interventions that the state would pay, for example, for some physiotherapy interventions. Clearly, there was manual therapy there. Probably delivered by the doctor, specialist in physical medicine and rehab. But, it was manual therapy there, spinal manipulation and so on. So it's been accepted by the system, for a long time, from the medical system for a long time. If I go outside, if I kind of forget about manual therapy in general, I actually come from we sort of move to osteopathy. I think sometimes, I don't know, we don't seem to be confident about our own kind of competences and where we come from. We want to, do we suffer from some kind of imposter syndrome where we think, we're not good enough to play Champions League football, so I need to kind of undermine my own kind of beliefs. So when I go there and I lose the match, because I kind of, some of my players were missing, kind of thing. I had too many injuries and so on. I don't know. It's a little bit of that. I think we want to see ourselves like the others, and that's historically. And for people that never read that paper, I would encourage people to read Hoover 1964 paper on ecological medicine. In the world of, for a long time, the profession tried to align themselves with the medical field, because that was regulation, that was recognition. So we ended up very much, we're different, but we use a biomedical approach. We're looking for where is the dysfunction, where is the cause of the problem. We fix that stuff, and there's a miracle, and so on and so forth. Things changed, and now it's also, I find it quite hilarious, to be honest, when people kind of and it's actually not just osteopathy, and people kind of use the biopsychosocial models, the new kid on the block. That's 1977, right? That's a long thing, you know, a long time that the new kid on the block has been around in healthcare, but it seems like it's a new things kind of explanation for everything. Now, the funny thing is, we seem to kind of worry too much about manual interventions and so on. I don't think sometimes patient care at all, okay? And for example, you know, my experience working, you know, 4 years in the Middle East, and, you know, still going to Saudi Arabia for teaching and kind of, you know, sometimes advising patients and so on. There's a world out there, actually, the patients kind of get some stuff from YouTube and send you on WhatsApp and ask you, do you do this technique? So actually the world today is a world of kind of people looking for miracle cures for stuff. There seems to be, you know, lots of kind of unethical professionals around selling, you know, snake oil everywhere, cracking everywhere. And, you know, believing, oh, yes, I remember very well a patient that I was treating and sent me some videos about techniques for a deviated septum, which he did have, and asked me, you know, do you do this technique? Do you crack the nose back in place kind of thing? Because this guy, another profession, but, you know, this guy kind of shows that, you know, I have enough, you know, I have enough money. I might go to the United States and see the guy to pop my nose back in place. So that's around, you know, and actually we kind of say, yeah, but manual therapy isn't cool. I don't think also all the patients want to hear us talking about the pain is in the brain, okay? Because, you know, that also got to the extreme where, and I was one of the guys doing that pain kind of education stuff quite heavily with my patients, but I got also to the point to say, I haven't got a clue what I'm talking about. They don't have a degree in neuroscience, okay? So I kind of just lost in translation. Yeah, it's a pain in the brain. And the patient said, yeah, what do you mean? It's upstairs? Is there something wrong with my psyche? You know, am I kind of, you know, do I need to see a psychiatrist kind of thing? So that's one of the things. People want to talk. People want to be reassured. I think, you know, lots of people are scared about their problem, and the simpler, the better. And yeah, and actually that was very well illustrated, the post-COVID need for people to kind of have social kind of contact, being touched, okay? Being sort of listened. You know, the patients that, you know, if you look at studies or ask for people kind of opinions about going to the GP, and, you know, the first thing they probably tell you, oh, the GP didn't have a look at my problem, didn't touch my area. So, you know, people want that as well. So you know, if we just say, oh, we don't touch because for example, there's no reliability whatsoever on palpation. Of course, we know that. Okay, but you know, one thing is to look for stuff, you know, some kind of spurious kind of paradigm of some whatever dysfunction you want to, whatever you want to call it, somatic dysfunction or something else. You know, you can look for that, or you can simply, you know, diagnostically, the hands are still powerful things, and, you know, even in terms of finding red flags, right? You know, I'm just going to do an abdominal examination. Oops, there's something here going on. I'm not sure, but I'm going to send you. So that's touch-based. That's kind of attention to what the patient, it's listening to the patient, it's reassuring the patient. So yeah, actually, from what I found and from your clinical picture and my reasoning and so on, I don't think is a serious stuff going on. So that's, but it needs to be contextualized. I can't just talk to the person and talk, because say, you know, you didn't have a look, you know, you didn't feel it. Okay. So whatever, of course, I'm not proposing that we need to find bits that are dysfunctional and fixing their bodies. That's not at all. But yeah, also understanding where they're coming from. Expectation is a big thing these days. You know, if you don't, do we ask our patients what to expect out of the whole thing? If the guy says, well, I just want you to crack my neck, and you may say, well, actually, you're probably in the wrong place, right? So, you know, it's a complex world. And I think, you know, sometimes we just punishing ourselves is going through some kind of a cleansing or whatever, kind of a spiritual cleansing of the profession, get rid of some of the stuff or whatever. It's going through purgatory. And if you believe in that concept, so I don't know, that's my take, you know, some of the stuff.
I think I'll put on the references, but I think it was a 2018 paper that came out in an American journal, in a medical American journal. The chief complaint of patients, and they assessed, like, they interviewed thousands of patients, were exactly, I left the hospital, I left the room having no clue what's going on with me. I have no idea what I have, and the doctor didn't even look at me. There was not even didn't even recognize me or look at me or touch me, and I'm more confused than I was before because I have no idea what I have, and I've just been to a doctor. So that's kind of the chief complaint. Dr. Kesava, were you going to say something before my next question? Were you going to say?
No, I was just nodding, and I was just going to ask George if he can refer me to the practitioner who can put my septum back, because it's definitely deviated. It's been broken twice, but I wouldn't mind. But I'm sure they're going to charge me like so much, so I don't want to go for the treatment.
Sure.
I kind of agree with George. I think one of the main things that kind of cost this anti-manual therapy, at least coming from India, it's like when I trained back in 2000, early 2000s, there used to be so many manual therapy workshops. It used to be a fashion. It was like your designer wear or the Ferrari car. So if you did some trigger point release, they used to have weekend courses to learn trigger point release or myofascial trigger points and stuff. So I think there was quite a lot of aggressive marketing that went on, probably that kind of put off a few physiotherapists or many physiotherapists or other practitioners. And then, once something gets really fashionable and a lot of people do it, then definitely it will be followed by questions of efficacy. Why are you doing this? Why is it effective? Why are you spending the weekend there? And also it resulted in some really not so skilled practitioners. Skilled practitioners teaching those courses too. So then it kind of became a money-making thing rather than genuinely teaching manual therapy. I think any manual therapy or any techniques for that reason, any profession taught by really good teachers, it's quite valuable. It's quite knowledgeable. There is a philosophy. There is when to do it, when not to do it. What is the red flags? But if then the intention changes to making some quick gains, then the quality drops, and that'll invite a lot of criticism. I think some of the criticism that we have seen about manual therapy probably kind of hinges from the fact that my colleague could make easy profits over a weekend course, whereas I couldn't. I'm a physiotherapist in a neuro ward dealing with head injuries. So there's always those palpable tensions. And I also I also think that it's always good to put a critical reflection on. One, when we put a critical reflection on, we shouldn't indulge in too much criticism of ourselves. Critical reflection is different from self-criticism. Sometimes I tend to see a lot of self-criticism. Like we either want a black or white approach, hands-on or hands-off. Whereas osteopathy is a beautiful profession. It gives us the scope for doing both. It's hands-off when we're asking questions. It's hands-on when we are doing stuff. And if you come to New Zealand, like the GP's appointment is 10 minutes. I don't know about UK, or I don't know about how it works in Italy, but it's 10 minutes GP appointment, and you're allowed to just talk about one complaint. So if you have like 3 or 4 complaints, I could have 4 different complaints, but I can't talk about it. I just have to pick the main one.
Wow.
And talk about it. So no wonder like this 2018 study is telling that patients don't feel satisfied, are more confused. I often come out so confused that I've actually stopped going to the GP because I know I'm going to be given a Panadol prescription, whereas I can go to the supermarket and get Panadol myself. Whereas compared with osteopathy, where the minimum management time is 30 minutes. And of course, there is the other side of the coin is it comes down to what we do in the 30 minutes. And now we are assuming good practice. 30 minutes is a beautiful time to engage in biopsychosocial approach, patient-centered approach, including hands-on treatment. And I also listened to some narratives where when people say I like biopsychosocial approach, all of a sudden they mean that to be hands-off approach, and I struggle with that.
Yeah.
because of the word biopsychosocial, it still includes bio. There is place for biomechanical things to be done. So you can't really take that off and then say it's a psychosocial approach. And I'm talking good practice.
Mm-hmm.
That leads me to my next question, which is going to be my last, because we're approaching at 1 hour, and it's very late in New Zealand, so it's 11. It's already 11. No, it's 11. Anyways, 11:30. So I mean, I go to bed at 9:30, so for me, like, wow, hats off to you at 11:30. But you have this recent paper. I talked to you about this paper offline. This micro RNA that involved in some neuropathic patients. There's this. I like this stuff so much. I mean, the biological mechanisms, the neurobiological, whatever biology we want to. Because there's room for that, right? There's room for what's happening in terms of biology. There's, in terms of the effects or whatever the underlying mechanisms of touch or this or movement, exercise, whatever. There's room for looking at that in a quantitative fashion, like what's happening really here. So I know this is a very complex question, but what can we, since your PhD also started with this research question, and also George, and we've been discussing this, no? So this contextual factors, there's a lot of stuff going on, but what can we say about the mechanisms of manual therapy approaches? What do we know? What can we say? There's no evidence for this type of claim, or there's more, it's heading more that direction. What do we know more about the specificities of tissue changes in all of that thing? What can you say about this? Am I clear the question, or?
I think I get your question, but I wasn't sure whether it was for me or is it for George to start.
Okay.
No, for you.
For me, okay, all right. So I think George would agree. I think it's an area that we are still working on.
Yeah.
Like I can't clearly say like this, like we are at the crossroads, but I can't say this is the way it is going to go, or this is the way it's going to go. I think we are, and the good thing that I'm noticing is a lot of people are talking about it. Whereas when I started my PhD, I could probably name a few researchers who were interested in mechanisms of manual therapy, because back in 2015, biopsychosocial was the word to go. Just like our trigger point was the word to go in 2003. 2015, when you talk about mechanisms of manual therapy, it's like, one, why manual therapy, and who cares how it works? So now there's more people talking about it, which is great. And we need to know how things work, because one, it clearly would identify what our strengths are, when to use it, whom to use it with, who are our responders. And in many ways, I will probably stop wasting our resources around some of the techniques that we may do that's not going to benefit a certain population. And this whole neuropathic pain research emerged out of clinical practice again. I started seeing a lot of neuropathic people with neuropathic pain, especially after diabetes. Some of them would improve, some of them won't. And you start looking at why some of them are not improving, and there will be like probably 10% of your patients that's coming through. But then they are the ones that are utilizing a lot of resources. They have seen every practitioner in the city, or they've been through everything very like religiously, followed every advice, but still not improved. So then there should be something. That's when we kind of trace back with something like diabetes or diabetic neuropathic pain. It gives you the scope to kind of trace back. So where do we start? Unfortunately, one of my collaborators is a physiologist at the physiology department here at Dunedin, and they were doing some research with microRNAs in heart diseases and diabetes. So it was then easy to ask the similar question to say, okay, is there any microRNAs that's involved in neuropathic pain that we can identify and probably target longitudinally with the multidisciplinary approach, and see if we can use them as a diagnostic or a prognostic marker. And the aim there is more like a preventative approach rather than, say, osteopathy for diabetes. That's not what we are thinking here.
Mm-hmm.
We are thinking about type 2 diabetes and neuropathic pain. That's our main target, and how we can probably prevent the certain 10% going into that chronic framework, where they start to utilize so many different resources.
Yeah.
So I would say mechanisms, it's exciting times. That's what I'm going to say. And I haven't come across any techniques that we shouldn't be using. I haven't come across anything like in terms of, say, safety or patient concerns. We still put our clinical hat on and ask all our questions that just we will do with any patient's thorough case history. Is there any red flags from a case history? No, proceed. If any doubts, stop. They're called red flags for a reason. We don't drive through the red lights until unless you're from some countries which where you can get away with that. But generally, red means stop. But I haven't come across any research as yet that shows you should not be using these techniques on these patients. And I would like to know what George thinks about this.
George.
Absolutely. So I actually start with the last bit, which is, again, if we polarize the discussions on the profession around the intervention, the manual therapy, we forget the profession. And the profession is, first and foremost, with primary contact practitioners. And as primary contact practitioners, there's clearly a role here, safety, to, a lot of patients, you can do very nice triages, kind of more haven't gone to the doctor, is actually coming to see you for their musculoskeletal problem, for example, or their visceral problem, whatever, it's an opportunity to say, it might be a good idea you go and visit, your doctor, whatever, having blood tests or something like that. So there is that part that clearly is not about the intervention, is the other part of the profession that tends to be forgotten because, then the discussion is all polarized about, does it work or not? Because there's a confusion between osteopathy and osteopathic manipulative treatment. We are not OMT, okay? And of course, if you put the discussion in the context of American osteopathic medicine, yeah, okay, it would make sense if I'm a family doctor, once I'm an osteopathic physician as well, and I do OMT as part of my whole thing. So OMT probably is a small element of what I do as a practitioner anyway, and it's an add-on to what I do. Of course, for us, yeah, the hands-on is the primary thing. Of course, it is, but that's not the only thing. So there is that sort of diagnostic side of the profession, the kind of, listening to understanding the person. Also for a long time, again, the whole thing about discussions on person-centered care, we kind of talked about that many moons ago, okay? But, never got on paper and publications because, osteopaths tend to be lazy when it comes to publication, okay? Or were, not anymore, I guess. But, there's a lot of that stuff, we always said to, remember talking to students, say, no, we don't treat the low back pain, you treat the person with the lower back pain. Again, that became fashionable now in other professions. Oh, yeah, we don't treat the shoulder, we treat the person with the shoulder problem. Okay, right, that's cool, all right? So that sort of person-centered approach, which starts at the beginning by kind of listening, by understanding what's going on, again, they're very popular and evidence-based approaches in the literature these days. One, cognitive functional therapy, starting with us, tell me a little bit about your story. Not dissimilar to what osteopaths have been doing for a long time. Tell me a little bit about you. How does this impact on you as in your quality of life, in your activities of daily living? I'm kind of this. I feel like I lost my agency. I can't do the stuff I care about. Well, guess what? That's the psychosocial side of things. With me just trying to understand what's wrong with them. Do I do a psychosocial intervention? Of course I don't. But if I get the person also on changes in terms of mechanisms, if the intervention gets them to start moving better, the intervention helps them understanding what's wrong with them and what they can do about empowering them, achieving minor kind of improvements in activities of daily living. For example, being able to go to the toilet, having a shower and so on. That has a huge impact on the other side, which is, their mental and social well-being, Yeah, sure, I can go shopping. When I go shopping, I stop there and I have a coffee with my friends, Okay, isn't it? So it makes me as a person, as, becoming an agent again, I can do my stuff. So there's a lot of things here that clearly the hands-on can promote that. And I think, the research on mechanisms is critical. I always believed that. I've always been a guy much more interested in mechanisms than in kind of outcomes. Does it work or not? What's the kind of RCT kind of thing? Was never kind of my main interest. I've always been sort of very interested in, what's going on in the black box or in the system or whatever. If I get the person to start feeling better and so on, overall, yeah, I affect the biological side of things. I affect the other stuff. I affect their ability to interact with the world, and on the research that we kind of pursued, you talked at the beginning, free energy principles and so on, understanding that at the end of the day, what's the role of the nervous system ultimately, making sure that you were around the planet for a while, survival, isn't it? So regulation acts, preempts things, predicts outcomes, does the best to achieve those outcomes. So of course, if I feel better in an intervention, everything, the whole package is better. Yeah, probably the intervention as a package had an impact on the biology, and so you can probably see some changes in biomarkers and so on, which is quite cool, quite interesting. So it's not the technique. Because you're going to do is that what's the difference between HVT or a muscle energy or a cranial? Again, we could have discussions forever around cranial, for example. Do I believe in the old sort of Sutherland model kind of thing? No, of course I don't. Okay. But does it work? Yeah, it does some stuff. Okay. Some patients like it. Some patients feel really good about, what's the intervention on? Probably you calm down some stuff. Probably you kind of modulate some stuff. And when you modulate something, it's not on the biology alone, is on the whole thing. But of course, the whole thing, well, ultimately reflects probably on the biology, So looking at, what's the effect on intervention on the biology is, I think, is quite important. It's and they were attempting, years ago with the Americans looking at some biomarkers and so on, or some sort of in vitro studies looking at strain on cells, and so on. But again, that's very little and so on. I think, but the little things, can add to the bigger picture. So does it work? Who knows? How does it work? I think it's a cool question. It's a really important question. How does it work? You started at the beginning, Bruno, talking about, the kind of blogs and so on from Chad Cook and so on. There's also, at the moment there is work going on and trying to kind of come up with, an agenda for research, and, it's part of one of those studies. And, one of the recent papers we published around try to, propose some stuff that's clearly a lot that can be done. Okay. Because, you could ask exactly the same questions to the other interventions that people claim have a lot of evidence, such as exercise. Okay. And see, are they kind of effective or not? And what's the best kind of exercise? Again, it could go on core stability, the strong kind of 1990 stuff, and everything is core for everything, to the point, actually, it's not enough just to do core, okay? Because, these guys are now start moving like robots and pretend, and protecting themselves too much, and then have back pain and have fear of movement because they were told to kind of, get your pelvic floor as tight as possible and your TA before you move. So I'm kind of quite excited about some of the work and can come out on kind of research on mechanisms. I think can give us a really, it's a good lens to look into the person, and it's not just changing their biology, because I think if you changing the biology, for me, kind of I look at the whole individual there, that the biology may change, but that's probably had a much broader effect on the impact on the whole kind of person. So
yeah, I mean, I'm compared to you guys, I'm low weight. I know I'm low. I'm how to say I'm still doing a master's now. So but
it's okay.
From the perception,
don't undermine yourself.
Yeah, but from the perception of someone that also teaches undergraduate students and has a lot of interest, and I feel I study a lot to this, especially the last few years with this neurogenic pain and neuropathic pain. I find it, and sometimes I have to bring all that sort of information and even evidence from physiotherapy to the osteopathic world, when it's because it seems like that. It seems like physiotherapy, for instance, it's much more involved in some types of research and very high quality papers. For instance, changes that happens with some upregulation of some genes of some proteins that are responsible for sensitive to oxidative stress, for instance.
Stress, yeah.
And what happens within certain techniques like neurodynamics or movement or whatever that changes that regulation that modulates pain. All of those underlying mechanisms. I think it kind of, for me, it's important because it kind of validates some of the techniques I'm trying to apply, and also explains why some patients don't improve. But of course, we all know this is very much regulated in terms of a central nervous system and neuroimmune system, neuroendocrine system. And there are some very cool papers about that. From this perspective, it's like, it feels that we need both the discussion of this type of quality research papers. We can clearly explain certain things. How can we translate this into the clinical practice? It's very important. This type of communication, which I feel it gets lost in communication between academia and universities, and from universities to students, and from clinical practice, and also the dialogue between, let's say, classical osteopaths and more the contemporary ones. It feels like ones are all about research and qualitative methods and very, very high-end methodology, but then other ones are like the nature and human nature and nature in general is way too complex to be studied. So I don't care at all about research because we can't even assess 1% of this. So it feels like, that's why I started the discussion with this. It feels like, this type of, but maybe it's just this noise that actually it reminds me of this idea of when there's a quadrillion synapses happening in each instant in our brain, and a lot of that it was called synaptic noise. But now it's actually important for the communication between cells. And maybe we have all this noise, but it's actually quite important to our communication and to develop as a profession. So I don't want to take too much long. So I just want to say my goodbyes and say thank you for your availability. I don't know if you have any final thoughts or otherwise.
I think I'll just add to what you're saying. Sorry.
Yeah.
I think, physiotherapy, osteopathy, I've been lucky to be involved in both professions. I think physiotherapy as a profession emerged from medicine. So the access they have got to health system, research, universities, it's always been there. So, to produce good research, high quality research in physiotherapy, it's difficult. I'm not saying it's easy, but they have the resources. They're well set to do those research. Whereas compared to osteopathy, especially outside of the States, it's either manual therapy or some sort of we have never spoke with the medical system really well. We've always, like in New Zealand, we've been seen as a complementary and alternative medicine for a long time before we were accepted as an allied health profession. So clearly there is a power structural differences why we are not producing high quality research. So sometimes when people talk about low quality research in osteopathy, it's like, hey, but the playing field is not level. It goes back to our debate of, if I don't know, coming from India, I can play cricket, but I can't play soccer, right? So tomorrow, if I move to Europe and someone is expecting me to play soccer, I can't because I don't know about it. So to produce research in osteopathy is challenging, no doubts about that. So with a lot of academics and researchers working overtime, it's great that we can produce some research. And then there's a debate of what sort of research we are producing, whether it's high quality or low quality. It's a different question altogether. So I'm inclined to encourage people, if you're doing research, great. Sometimes the low quality research is probably because they're not getting enough mentorship or support, or probably they're not with the right group. And all it needs is just like a conversation, and then it flips, and then they start producing weight and produce more good research. And we don't want to talk about, people engaging in repetitive low quality research. that's their personal probably choice. We will emphasize on good practice. And then, the debate around polarization with traditional osteopaths, contemporary osteopaths. Again, I think I would reinforce it. It's just like the society in general. People who want to be polarized take positions, take opinions, and form opinions will always do it, irrespective of how much evidence there is. And probably it might suit some agendas. We're all people. We're all human beings. We have our own agendas. We have our own opinions, and we want to take sides with people that we like, and blah blah blah. But I think the best advice I would give students again is like, I am teaching you evidence-based practice. I'm teaching you research. So then then I'm kind of inclined to reinforce that you should make your decisions based on your ability to read that evidence, not because Kesava said so. Yeah.
Yep.
Yeah. Don't do what I say. Just it's a very important. I rarely see a teacher saying, "Don't believe what I'm saying. Question what I'm saying, and do your own research, and then come to your own conclusions." It's very rare, especially in Portugal. I don't know if it's especially in Portugal, but there's a lot of that. I'm the guru. I'm this is like this, and then you follow what I'm saying. And
it's human nature.
Human nature. Yeah. Okay, thank you, George. Any final thoughts, or should we just say goodbye?
No, thank you
very much.
It was a very nice discussion. Okay?
It was a very nice
discussion. For organizing it. Yeah,
very much needed.
Thank you so much.
Okay, Dr. Kesava, thank you so much. Have a nice rest.
Yeah, well, thanks a lot for the opportunity, and yeah, thanks. Good to see you, George. After 5 years, I met you very briefly.
Yeah. In Dubai.
Yeah. So good to see you, and yeah, thanks
you
again.
Too.
Okay.
Have a great day.
That's all. Bye-bye.
Okay, you too. Okay, bye. Okay.
Yeah.